I'm going to go ahead and we're going to move right on if you're good with that. All right. So you get to hear me read a little bit more. I would like to move to our keynote presentation on this first day of this meeting. It's my absolute pleasure to welcome and introduce Dr. Russ Glasgow, our keynote presenter. Dr. Glasgow is the Deputy Director for Dissemination and Implementation Science in the Division of Cancer Control and Population Sciences at the National Cancer Institute. Dr. Glasgow earned his Ph.D. in clinical psychology from the university, specializing in the design and evaluation of practical and generalizable behavior change interventions, especially using interactive technologies for use in a variety of settings. He's published over 400 articles and been the recipient of numerous awards. I've admired and been inspired by Dr. Glasgow's work for as long as I can remember. One of my earliest areas of focus as junior faculty was in the area of diabetes, where I think it's safe to say Dr. Glasgow's a legend. It was through his work on DNet, an internet-based diabetes self-management project back in the late 1990s and early 2000s, not 1900s, that would be terribly inappropriate.
I am old, but...
where I first became aware of the work Dr. Glasgow and his colleagues were doing. I had just joined the Center for Behavioral Medicine Research at the University of Virginia and was working with a core group of psychologists focused on behavioral diabetes. I quickly learned that this was a small, tight-knit group, not dissimilar from what ISRII is today. My closest mentor and one of my favorite colleagues, Dr. Linda Gonda-Frederick, was a key member of this behavioral diabetes world. And whenever Dr. Glasgow's name was mentioned, she would ooh and ah about him. Certainly, Linda's not alone. Dr. Glasgow is a highly sought speaker, collaborator, and author. In fact, when Deb Tate and I worked on a special series for the Annals of Behavioral Medicine focused on the science of internet interventions, now published several years ago, we knew Dr. Glasgow would be the perfect person to synthesize it all and write the key discussion piece, and he was, which may be most enduring. His development of the RE-AIM model, a model for the planning, evaluation, reporting, and review of translational research and practice, has already been incredibly influential. Its fit with the work being presented at this conference is perfect. I've seen Dr. Glasgow speak a number of times and have never been disappointed. And now, with this bar set somewhat high, let's welcome Dr. Glasgow.
Well, thank you so much for that overly generous introduction, and this could be the first time you're disappointed. We'll see. But let me first of all thank you and David and the planning group for this, and congratulate ISRII. I really enjoyed the history. As you know, in the spirit of transparency, I'm not all that familiar with the group, but I want to be from here on out. So that's going to be a hard act to follow, and I'm really honored to give the opening keynote here. As Lee mentioned, I will focus more on what some people call the latter end of the translation spectrum, what otherwise known as the T3, T4, or as we say, implementation and dissemination science. But I will take the opportunity, particularly since I think another first is being ahead of time. I don't think I've ever been introduced to the meeting to be ahead of time. I'm used to figuring out what 5 or 10 slides I'm going to have to cut out, you know, so we'll have a chance to make this more of a conversation rather than just death by PowerPoint. The other thing I want to say is that in some ways this is a bit of an old home week for me because of that embarrassing long discussion. Some of my roots actually are shared with people that are key to your organization here. I'm a classmate and longtime friend of Ricardo Munoz and Brian Donaher that just walked in. A key part of your organization was, I think, a year ahead of Ricardo and myself at the University of Oregon, too. And we've all maintained our connections over the years. So it's kind of a special pleasure, and I'm looking forward to meeting many of the rest of you. So here's what I'd like to do, and I think we do have actually a full hour to do this. So the official part of it, I'm from the government, so I'm here to help you, right? So the first part of this, I'll give you some of the official party line and go over what I think an implementation science perspective is on ISRII that's relevant, both in terms of opportunities and challenges. Mention a couple of the models that Lee referred to. The second thing that I want to do here is to focus on pragmatic approaches. And for those of you that might be interested in funding, the avenue, to my knowledge, in terms of applied research, certainly implementation and dissemination, and I'd go so far as to say maybe your area's application too, that's kind of lit a fire under some people at NIH, and I'll say more about what I mean by that and some of the opportunities. Then I'm going to do something a little different. The third topic that I'd like to focus on is to share some of my own reflections for the future and some possible futures, and hopefully engage you in talking about that. There's a particular study there that you see we named for David, my own health report here, and I'll tell you a little bit about that, which is a current study that's in the field. And then I will ring a bell and wake you up from your postprandial slumber at the end and talk about funding, which I realize is usually all anybody wants when you invite an NIH person to do. And we do have a little bit of funding, actually, that you might be interested in. So, with no further ado, I don't have any conflicts that I'm aware of in the traditional sense. Often what I say does generate a little conflict, and we'll see if that happens or not. But our elevator speech, my notion for implementation science, what it is and notice the word rapid, I think is relevant for this audience. Sometimes hard to achieve, but we'll talk more about that. But the rapid integration, and I prefer the word integrate, is a little more condescending, or kind of implies that we in the ivory tower have all the answers and we're going to come down from on high and share our wisdom with the poor masses out there. But the integration of scientific evidence or research, practice, and policy. And I also want to highlight the policy, because I think that's an area for all of us that we can do more on than we have so far. If you're interested, our website that does have a variety of tools is listed at the bottom. Quick orienting assist for me here. Would you raise your hand if you know about the REAIM framework or have heard about it? Okay. Could you keep your hands up if you're sick of hearing about the REAIM framework and don't want to ever have to hear Glasgow say anything else more about it? So, well, I promise there will actually just be a couple of slides on it, but this is one or two of them, and then I have one new model to share with you as well. What I did was I tried to reframe REAIM for those of you that aren't familiar with it, with the words in red. REAIM is an acronym for reach, effectiveness, adoption, implementation, and maintenance. The reason it was created, and we still stubbornly feel it may have some application today, I guess about 14 years after the first publication on it, is that we at least argue that it can be helpful in the planning or the design, during the, which is where it's been most widely used, but also in the review and helpful synthesis of the literature, because it helps us focus on some often ignored but critically important issues if we're concerned with really walking the talk and translating something into real-world practice. So you can see these terms here, and I won't go into detail. I'll be glad to take any questions. But what I'm trying to do here is to merge this framework with an interesting realist perspective. And since there's a lot of Europeans and some Canadians here, can you raise your hand now? I'd also like to know if you're familiar with a realist perspective. Many people familiar with that? This usually happens. I'd strongly recommend you to do this. This is an area, like much of implementation science, where frankly our Canadian and UK colleagues are ahead of us. But what, in a nutshell and an oversimplification, what a realist perspective is in contrast to the way we usually talk about doing reviews in the US, whether they're Cochrane or just traditional literature synthesis, where what we look at is the average effect across everything, across all the studies. What's the average effect size that's been produced? A realist approach is much more contextual, which is what makes it appealing and congruent with an implementation science approach. And it asks the who, what, where types of questions to understand. And in my own perspective, I'm not arguing we should throw out Cochrane reviews by any means or things, but I think a understanding the contextual factors. They have to do with technology, they have to do with target populations that I think you're also all familiar with, but it also has to do with other issues like the multi-level environment that it exists in, the policy context, and things like that as well. So we may come back to that, but this is kind of re-aim framed in a realist perspective. The other thing that I'd like to point out is an issue of re-aim that I know you all have dealt with some, and I hope, although I still see some amazingly ignorant comments made occasionally at study section about, well, nobody, that isn't a Ph.D., a white upper-class Ph.D., male engineer ever uses the internet. But I think you've overcome that. But there still are a lot of issues, I think, having to do with e-health and internet interventions related to health equity type issues that could be evaluated using re-aim or other approaches. And this is just a little slide that I won't go into the details of, but it's kind of a modification of a story that I'm sure some of you are sick of hearing me tell about re-aim and narrative. But for now, for today, if you just would look at this effectiveness dimension here, this has to do with our primary outcome. And let's say you have a depression study, you have a smoking cessation study, and it's focused on your primary outcome as well as any more generalizable or broader outcomes there. But let's say that whatever health equity issue you're looking at, whether it's persons of color, whether it's income, whether it's rural, okay, whether it's whether you're in a high-level patient-centered medical care home or a rural ma-and-pa practice community health center, whatever one you want, let's assume that that main outcome of the people that participated in the study was equal. Okay, that's what usual research does. It looks at, and the usual conclusion from that, if there's no differences there, well, there's no health equity issues here to worry about. However, let's look a little bit, and admittedly these are hypothetical data, but for our other broader story, we've worked these out in models, and you can do various types of modeling on them. But if you ignore the other aspects of the re-aim model or similar approaches to population health, if you don't look at the reach, what were the characteristics? Who was able to access and participate in this? If you don't look at the adoption, and this is a key thing for those studies that are not just, done general advertisement or a blast email or something like that, but if you're working in a setting, like a primary care setting or a work site or a hospital, how many places can do that? Is that really generalizable, or is that just done in the places, like I do a lot of EHR research, medical, is it just done in the places, the VAs and the Kaisers of the world that have the best access? What about the implementation and maintenance issues, particularly in things like tobacco or weight loss or whatever, where the social environment is so critical there? What about those factors? If we still have to end up to the overall benefit being less than 1/4 for whatever disparity that you want to focus on. So that's just kind of a thought piece on re-aim. And with that, I'm going to move ahead to a different model and a newer one that I've been fortunate to collaborate on with Larry Green and Kurt Stange and Martina Taylor that we call the evidence integration triangle. I realized from trying to do a number of workshops and training people on re-aim, and especially trying to introduce re-aim to practitioners, it was like most of our theories, a little egg-headed and ivory tower, and people didn't quite get it. So I figured we could have no more than 3 things, okay, with this population, given the way media is going these days. So our 3 things, to make it as dirt simple as we possibly could, about what's needed to successfully translate research into practice, is number 1 at the top, and, well, first of all, it begins with, if I can make the cursor work, it begins with 2 things, with evidence and stakeholders. And the key point here, you'll hear me, regurgitate this until you're sick of it, but it's so critically important. You need to meaningfully engage, not just have a little, one-time meeting with advisors that you give them donuts and then go do what you were going to do over anyway, but significant, ongoing, meaningful engagement with stakeholders. And it begins with some type of an evidence-based program. This can be a guideline, it can be an intervention, it can be a policy. The way most of us are trained, and frankly the way most of my colleagues still think about, is mission accomplished, okay? I published in, really respected journal, JMIR or JAMA, and so mission accomplished, okay? Well, we all know that's just the start of the story. That doesn't get us there. What we've argued is we need at least two other things done in an integrated fashion. One, we need some practical measures of progress. And regardless of whether you're talking about an individual project or a community level or a hospital-based quality improvement project, you need to have some practical measures. I'll come back and give you some examples of this that are possible to be used in the real world of your progress towards your goal. One of the reasons why is that hardly ever, at least in my experience, do things work perfectly when you started out or when you try to replicate that great gold standard study that you saw in the journal, because your context is different, your population is different, the time is different, you're always going to run into things. So you need that. And then finally, and this is easy to give lip service to, but hard to implement, is even with the world's best evidence and the world's greatest measures that you have, even if you have the world's greatest internet dashboard to tailor it and give them feedback, if you come in and do this in a way that's arrogant, that does not engage your target audience and things like that, it's not going to work. And again, unfortunately, we have all too many examples of that. So the point of this triangle is you need all three of those. We also call this the necessary but not three, and the idea of the arrows there. In one version, I had the feedback things going, but I thought that was a little too much and might introduce some seizures or something. So it's just, you know that this means that's supposed to indicate the iterative and the feedback nature there. I think I'm going to skip this one, other than if you can pick up a few phrases there. I'm going to come back in this example that we call My Own Health Report and show you how we use this model for an ongoing internet study, or at least that largely uses a lot of internet infrastructure in background, where our goal was to try to make actionable U.S. Preventive Services Task Force guidelines on not one, not two, not three, but 10 different health behaviors and behavioral health or mental health issues without taking a huge amount of additional time, which I know sounds like a fool's errand and may turn out to be an impossible task, but we're having fun with it anyway, and I'd like to share a few thoughts. So with that, let me turn a little bit and talk now about some pragmatic methods. The other thing is, after ISRII is officially finished, or David will let you go at night, I'd recommend, he said he and the Chamber of Commerce would kick in if I threw a few Chicago slides in. So I would highly recommend, and this is serious, the Architectural River Tour. It is astounding if you haven't done that, to try and do that after the meeting is over there. But talk about, I've decided for at least my group, this is the year of pragmatism. I don't know what it is in China, but for us it's going to be the year of pragmatism. So we've talked about a couple of pragmatic models. I'm going to talk about a few methods here and then give you the example of some pragmatic measures too. But again, a quick show of hands so I know how fast or slow to go. How many of you are familiar with the PRACES criteria? It says at the top, the Pragmatic Explanatory Continuum Indicator Summary. Okay, so we have some work to do here. I'm really excited about this. This is one of the things that I'm jazzed about. And the reason why is I think it's a meeting of the minds between the more traditional, if you will, basic efficacy researchers and the more applied effectiveness or implementation dissemination researchers, where we can come together. In my own experience, and I have to confess to being part of this sometimes, this often rapidly denigrates into a mud wrestling contest about RCTs are awful and the scourge of the world, or RCTs are the only type of evidence for any question that you could ever have, and you can't trust anything else whatsoever. That's usually what we see. Obviously, life is more complicated than that, and what this does is this is a continuum that is one of the other things that was put forth by the Consort Pragmatic Group, of which I believe David's a member, right? Are you? No, you're a member of some of the other ones, not that one. What it is it lists 10 dimensions that are shown here that along which you can plot a given study about how relatively explanatory or efficacy it is. You think earlier more highly controlled, more focused on internal validity versus pragmatic, which is more dissemination focused, like Ricardo's work, focused out there on the, you know, scale up, getting it out there, a trial. And the notion is no trial is completely explanatory, no trial is completely pragmatic, nor should it be probably, but rather than these kind of bold statements and arguments about it, let's be more transparent and just show along important dimensions where it's pragmatic and where it's explanatory. And the really cool thing about it, that's kind of the background, but they've developed this cool little simple figure. And I'll try and go slow over this, and if you're still puzzled, raise your hand after I do this, because I realize after you get it, it's really simple, but until you get it, it looks a little strange. So we're contrasting two hypothetical studies here. Okay, again, they're the ones I told you we would never see, but the one on the left, what we do is let's just take one dimension, and the dimension I'll focus on here is the flexibility of the comparison intervention. There's a dimension for both the experimental intervention and the comparison, because this is for trials or CER studies or where you're comparing a couple different interventions here. How much practitioner expertise is required. And along each of these, we have a line that represents a dimension all the way from completely explanatory down here, and an example of completely explanatory on profession or expertise would be this is only the world's greatest cognitive behavior therapist doing this. Is the only you have to have years of training to be able to do this. You have to be supervised, you know, trained for 8 months and supervised 8 hours a week, and every session has to be, you know, feedback and things like that. All the way out here, that would get a 0. Usually this is rated on a 4-point scale. This would get a 0 and be plotted maybe as it was on this study, like right here, close to the centroid. On the other hand, if you went out there and this was either totally automated or you tried to train community health workers or peers to do and deliver this, this might get a 4, and you would plot on this dimension out here towards a 4. And so what this does is show on all 10 of these dimensions, this study, because all of the dots here on this 0 to 4, these 0 to 4 dimensions were way out here, this was hugely, again, I've never seen one like this, hugely pragmatic study. In contrast, this one here is like maybe many FDA clinical drug trials. Okay, very, very explanatory, tightly controlled, highly selective, okay, that sort of thing there. Again, this is a non-judgmental thing. It's just showing how it is in being transparent. So let's take a couple real-world examples. Sanchez, we're looking at reviewing the literature, and this started with an exercise that we were invited to contribute to one of a chapter in Seth Noir's book, and their colleague Noir and Harrington. Many of you probably know about interactive health communication technology that Borsika Rabin and I wrote a chapter in. Based on that, we had, like many times, many studies, much more data than we could ever get into that. So what we did was we wanted to drill down a little more and focus at cancer-specific e-health interventions. These were internet, but also m-health. Some of them were in the old days, so they were even old computer CD-ROM-based intervention, but some type of tailored, automated, electronic assisted intervention. And we went through, identified 113 that met our criteria. I won't bore you with that, and submitted them to Precis review. So these are cancer specific. They could be prevention studies with like smoking cessation, or they could be during active treatment or even survivorship stage. But that's what we found. And in brief, the results that we found were kind of interesting. Is we found a surprising consistency. So much for that we went back and looked at all the coding and double entered everything, so we thought something weird was going on, is that there were very little variability in this particular study, and don't ask me why, but we still had the 5-point scale, but for some 5. So as you can see here, 3 was the average score, and the range, there was really a tight confidence interval, just was 2.7 to 3.6. So pretty much everything fell in the midpoint of this 1 to 5 scale on all 10 of these dimensions. Again, this is across these 100 and some studies. We did also, if you're with me and wondering how hypocritical I'm being today, we did also look, using a realist perspective, about contextual factors that might explain this notion and where there was variability. Was it year, that thing? Was it the modality? Was it the content? None of those things really seem to explain what there was there. But in addition, we also did in this study, based largely but not solely on the re-aim model, in addition to the 10 Precis criteria that I showed you, and I think I have a few examples here, in the future, we added some additional criteria that we felt were important for potential adopters or stakeholders that aren't covered in the Precis. So in short, we thought Precis was a great start, but maybe not sufficient. Some of these additional things were like, is there any emphasis on or training or plan or infrastructure for sustainability? How much did it cost? What were the resources, not just the dollar and equipment cost, but the staff training that was required? Issues like that are important for real-world dissemination. So we added those, and what we found is that these studies, and again, these weren't right up to date, but I think they were up last year. I'll have to look that back up again. I don't have. But it was over 10 years of e-health cancer studies. And let me just show you visually that so you don't have to take my word for it. First of all, these are the Precis scores here, and you can see here again we use the 1 to 5, but look at the consistency across there on that pattern, on this spider pattern. Almost every one of these is a 3, which was really interesting and a little confusing to us. In contrast, look at the next graph, same scale. You see how much more explanatory or how much less translational or pragmatic it was on these added dimensions. And these were things like, if you can't read this here, was there any report here of adaptations or changes that were made? This was program sustainability here. The cost reported here. Participant and setting representativeness. We saw these things done a lot less. And again, you can probably guess some of the reasons for that, but these are just the data. We'll interpret them a little later. So in summary, what we found was that this Precis criteria, this way of pragmatic thinking, was helpful. We particularly liked these coding criteria. We found that people can be coded fairly quickly from a variety of backgrounds to do the scoring reliably, that it was useful for this and other purposes I haven't shown you, but that we felt that Precis wasn't quite enough and that it helped to add these additional scoring criteria using this same notion and to use this spider plot there, and that it could help our science a whole lot if we were to do this to increase transparency. Okay, I promised you we'd have pragmatic measures too. So what I mean by pragmatic measures, and this is Truth in Advertising. This is a work in progress here, but Bill Riley, that some of you might know, who's one of the leaders in mHealth at NIH here, and I have worked a lot, and if you remember back to that triangle, the evidence integration triangle that I was talking about, we said one of the key things was you need practical measures of progress. This is particularly if you're working with a partner in a school system, a work site, a community, any type of primary care setting, something like that. You need something that you can use for a dashboard to know if you're making progress. Maybe nationally for Healthy People 2020. You need some measures that are feasible. The dietary example is that the gold standard is usually considered to be something like repeated 24-hour interviews that you send in and have coded, or like a 200-item dietary questionnaire that you also send off to have coded and get back. That is great, and nothing the matter with that, and that's wonderful when you want to do your research study, but when you're talking about trying to get something implemented in a variety of low-resource, real-world settings, that's pretty much a non-starter, okay? It's just not going to happen, particularly if you don't have research. So we argued that what we need are pragmatic measures that, have good psychometrics, or what I should say is good enough. Because we feel, and there's a lot of examples here, that sometimes the perfect is the enemy of the good, and especially one area we feel where the perfect is the enemy of the good is our old friend that most of us talk about measures when we want to talk about a gold standard measure. We talk about internal consistency, or alpha, okay? Well, how do you do, what's the single thing that you do to increase high alpha and get published and everything? You have a hell of a lot of items that all say the same thing. That's how you do that, okay? And that just doesn't work in the real world. So we need to relax and think a little differently. And our argument was, again, not that you shouldn't do the gold standard research, but if you're considered with the pragmatic measure, you need some other measures that are more adaptable to fit in real world context that have the criteria that are shown here. And again, this is the second time, you're going to get sick of hearing me say it, it's something you work on with your practitioners, with your stakeholders, with the people that are going to have to implement this and stick with the program over time. It has to be important and meaningful to them. The burden has to be low. A critical thing is, if you're going to use it, it has to be sensitive to change. So obviously it has to have a certain amount of reliability, otherwise it's not going to be sensitive to change. It has other additional criteria, and we thought a lot more about these. But because the reason being is we feel they're all helpful and important, but we also realized that there are relatively few of these measures out there, and if we had said you had to have every one of these, we'd be creating a situation where nobody would ever meet the bar and everybody would just throw up their hands and say, might as well not do it. So anyway, think about what you will about this, but that's our argument why we need more of these. If you're interested in the notion of pragmatic measures, or more generally, measures for either behavioral science in general, implementation science, there is a website, this is the little advertisement that NCI runs, called Grid-Enabled Measures, or GEM, as we call it, GEM, and the homepage is there. And an exercise that was led by Borsika Rabin, and my office participated a lot in it, was to attempt to identify both gold standard and practical measures that can be used consistently in a more harmonized. That's our new buzzword, so we don't sound like we're the Russian government and say standardized, harmonized measures that we're using to try and enhance the science by having, more common, compare apples to apples instead of apples to oranges. So instead of each of you developing your own scale for engagement with internet, or your own measure of reach, or your own measure of outcome, let's see if we can have some common measures, that would work across studies to be used. We feel that would enhance the science. And anyway, there's a discussion there, and we've attempted to not only use the experts and have at least a bit of a crowdsourcing wiki type experience where researchers and stakeholders, participants can engage and discuss their experience with it, measures and things. To be honest with you, we've gotten people somewhat like yourselves, although I'd be curious, have any of you been on GEM or participated? Hendrix is. I don't know if you count or not, Hendrix. You're let us to do that. A few others, David and a few others. Well, take a look at it. What we have not done, and would be a wonderful exercise, maybe even fundable, but certainly a good publication, would be if somebody engaged some of these people I've been talking about, these real-world stakeholders, to see what's important to them. We've done a reasonable job of saying what's important, I think, to the research community, but we haven't closed the loop yet. So I'm now going to go in and give you an example. First, a little soapbox speech about the importance of practical patient report measures. These are related to, but different than the pros that many of you might know about, particularly if you're into cancer research or some areas of mental health or quality of life. You might know about the PROMIS websites that have standardized and computer adaptive measures, which are great. And we have a few of those, but these measures in general are even briefer than those. And what we did was trying to bring both experts and stakeholders together, did a series website to identify, again, being gluttons for punishment, these 10 different domains that are important to primary care, that primary care would like to work on, that there's unfortunately convincing abysmal evidence that primary care does not do a very good job about addressing these health behavior, mental health issues on a consistent basis across the board. Not generally through any fault of their own. It's kind of an impossible situation when you have 10 minutes with the patient to even address their presenting problem, and you're filling out insurance forms and that sort of thing for half of it. But anyway, we did come up with the first amazing fact is we did find incredibly diverse groups, from patient advocates, frontline clinicians who we let have kind of the final say, researchers, health policy people. We were able to come up with, and you can see some of the measures here. But more than the individual measures, I want to tell you where we're going with this now. So we came up with these measures, and we did this in a pragmatic study. Again, this study rated really high on that Precis criteria, but a couple of things that I want to point out, how pragmatic studies differ from traditional research. And by the way, those of you that are looking at some of the comparative effectiveness funding, either from NIH or from PCORI or anything, these are the same criteria generally that PCORI looks at for CER research too. So again, I'll skip the first one because you're already picking the world's best settings. You have multiple heterogeneous, and generally you try to purposely select things that there's a variety of settings where the work is done. Comparison conditions, again, it's a tougher hurdle, but instead of showing that you're better than no treatment, okay, or placebo, well, big whoop. Pretty much anything is, showing that it's better than alternative treatment. So the drug example is, if you're going to come out with a new drug, which usually costs hundreds of thousands of dollars on things, show at least that you're better than the aspirin equivalent, okay? It really is no longer good enough to show you're better than no treatment, okay? Because that involves so much, and a lot of it may be placebo and that sort of thing. Show that you're better than an alternative that's out there. And again, it's fine to have your usual gold standard primary outcome, but we say look more broadly too. Doesn't have to be along Reame dimensions, but look more broadly at generalization effects, especially look for any unanticipated outcomes or consequences. So we're doing that in a pragmatic study that we call My Own Health Report. And I don't know, Lee, what we're thinking about doing is maybe giving a bar mitzvah for our MORE study, because we're not quite sure about funding in the future. But if you could help us rig this up, we'd be real open to it. But what we have done to this point is we've created a public domain, open source, interactive tool, web-based tool to administer not only those items, but also with the area like depression. I know this group was pretty savvy about. So we use the PHQ-2 item screener. If you're positive for that, then it goes on and administers the other PHQ items too. And again, since it's internet, it can be kind of adaptive testing, so it doesn't take much longer, especially if you don't screen positive. So we do that. We provide an immediate real-time feedback report for the patient and their family, and then another one for the healthcare team. Here with this tool, and it's also designed modularly so that, let's say you're a cancer researcher and you might like to use this, but you're really interested in cancer screening. Okay, you can also add a module on that as well, and won't take too much longer. Currently now is just 17 total items. Here's the website if you want to check it out, and let me just tell you a little bit about it. This is a mouthful. But what we've done is cobbled together, in this day and age where there's no money around, I had to go with my tin cup, and I begged the colleagues around NIH, particularly OBSSR and NIMH, and then especially Agency for Healthcare Research and Policy saved us with some last-minute funding for the end of last year, AHRQ. So this is a kind of trans-HHS initiative. This is a mouthful. It's a pragmatic, cluster randomized implementation trial. What I mean by that is we're looking at introducing primary care settings. We have 9 pairs of clinics. We have, I'll tell you in a minute, 2 types of clinics, but each pair, one of them is randomized to have early versus delayed intervention. To do this, to use this tool, the goal of this is to see how consistently can this be implemented and lead to meaningful goal setting, shared decision making, and a plan to address health behavior change. Again, being masochist, we didn't just pick the settings like the person that's running the website and coordinating for us is Alex Christ, who's one of the U.S. leaders anyway in electronic health records and primary care research, and they have a great EHR where they can easily dump this right into the EHR and everything. So we took them, but in addition, we also purposely took some border clinics that are largely Spanish-speaking and low literacy that are almost nowhere on the EHR. We had a whole lot of community health centers participating. We had a variety of some rural centers out there. So we purposely selected to have a broad heterogeneous sample, and you can see the different states that we have the clinics in. Why this is pragmatic is that it does have control. Being pragmatic does not mean that you give up control or good methods or science. Okay, so what's standardized is this automated assessment tool, the feedback that you get, the tailored feedback, the goal-setting materials, and guidance for follow-up in the primary care, how this tool is used. Some of them, like the Virginia clinic I mentioned, have a PHR, a personal health record. They push this out through that. Most of the people send out a couple email invitations ahead of time to just have them go on the web. A number of places do it in the waiting room. Okay, some of them, the low literacy sites, actually have to sit down and read it and have the staff enter it. One site is doing it paper and pencil, then entering it in there. So, and then who does the counseling varies on the clinic. Okay, the guidance for the counseling, the information, the feedback is standardized, but in some clinics they have behavioral health counselors that some of you know about is a big thing in terms of interactive technology, but others just are out there ma and pa, and there's only pa left to do the counseling, is trying to do it on top of everything else. So the goal in this study is sustainable routine use of this intervention. Enough about that. This is just a quick summary. I think I've mentioned most of these things, but these are some of the characteristics of the study. And again, this is a quite different approach, but if you use this Precis criteria, this ends up being about as close to pragmatic as you can get on the score there for the following reasons that you see there. The other thing that we've committed to do, because I feel this is a huge problem, is to be absolutely transparent about this, including the adaptations that are made in terms of the failures. And we are going to have failures. We know that we experience, because we think that's the way that we learn. Let me just check my notes here and grab one of these, do a Marco Rubio thing here. I think that what I would like to do is try a bit of a disruptive innovation, because we're doing okay time-wise here. So what I'd like to do, if that's okay with David and Lee, is entertain a few questions or interactions now. Watch it. I do have some other things I want to share, but this is kind of the first big information bolus, and I know I've been talking a while. So I'd like to engage people now, particularly if you have any comments or questions or would like me to clarify anything around this pragmatic approach, Precis. You have re-aim things, and then after a little bit of interaction, and you can get up and stretch and things, then I'll go back and drill down with some newer things I'd like to share about possible future directions that we can do, and then I'll end on talking just very briefly about funding alternatives. And there's at least a teeny bit of good news there, folks. So this day and age, you need to be sure and say that. So I'd be glad to take, yes?
Mentioned that these days it's really not acceptable to have a usual care or no treatment control arm. Do you think that's true with internet-based interventions where the efficacy really has not been demonstrated?
The question, could you all hear the question or not? No. The question was, do you think that statement about having to have some type of based interventions as well because the efficacy really hasn't been established? That could be an interesting discussion at the throwdown or something. I don't know. My own take from knowing a part of your literature, and again, I've been a federal bureaucrat just wasting your money for the last 3 years, so I haven't kept up on the literature as well as I should have. So I don't know. I would say in some areas, I guess, I would take issue with that. I'd say certainly some areas the efficacy hasn't been established. I would say in many areas, we do have pretty good efficacy data that something, an intervention, is better than nothing. And I think we are ready to move on. So I guess my question would usually be the weasel out, as it depends on the area there. In the area where we do have efficacy data, I argue that in particular, and this is another paper that has been in press forever, but it's coming out in translational behavioral medicine. My colleagues and I argue for something called a minimal intervention needed to change. This is a term that was first coined by Barbara Reimer and Bob Croyle in my notion, and again, it's the aspirin initiative. So let's say, for example, you're doing an internet intervention, and we know, I don't know, let me try to think of an example I don't have, but the most basic thing where you might just give people information, okay? You say, try and come back here and read this information and, try out these activities, but it's kind of static and things. At least, and maybe that's a little too pejorative, but we argue that we need much more of the or whatever, but we're looking at the minimal intervention. And why? Why do we push that rather than is what we usually do and what we usually fund at NIH is the maximal intervention? The reason we say that is because of these other re-aimed dimensions, is because usually the minimal intervention is going to have a higher reach. More people are going to be able to get it. It's going to be more widely adoptable in more settings. It may be easier to implement and that sort of thing. So again, that's not a given, but we feel that more of those types of comparisons are needed. There's a more interesting discussion, actually, in areas where, let's say, where efficacy is not established. And that's one I think I'll save for later or a discussion or the happy hour tonight. I at least feel, and I've gotten in a fair amount of trouble for this, that the traditional pipeline where you go from discovery to efficacy to effectiveness, I feel that's broken and that we've demonstrated pretty conclusively over the last 20 years that that model doesn't work and it never gets to the end. Instead, it just cycles back and cycles back in the basic things. But that's, again, a much more contentious and complicated argument. Yes, back here.
Speak about managing the signs of mixed explanatory pragmatic trials. We're in the middle of a large so-called mixed trial. I guess one thing we're finding is when you have a mixture of the qualification levels or anything you're looking at, there's an error bar essentially around each one of those things, which would be much more narrow to a traditional clinical trial of efficacy with the risk of a null study. So what are the broader scientific aims the NIH would be looking for from these trials that have a higher risk of failing in efficacy than maybe yielding other knowledge in terms of their pragmatic?
Excellent point. Again, I'm going to assume that you didn't hear that. Is that correct over here? And the question is, very astutely pointed out, when you're almost selecting for variability across patients, across settings, across practitioners, that sort of thing, so you're probably also selecting for variability. Your standard deviation, your confidence intervals are probably going to be larger, which generally means, not always, but it generally means you're going to need either a larger trial, or if it's the same size trial, that you're going to need more participants or whatever. So there's several different answers. It's a great point. The question was, well, where is NIH on this then? Are they willing to accept a larger chance, maybe of getting a null result or not detecting something, give that up for something else? That is a great question that I don't have an answer for. I would say I myself am. There is no one NIH answer. I realize after being there, each institute has a different answer to that question, and there are dramatic differences across institutes on that, and many individuals within an institute have a different thing. I guess where it is it comes down to, like many things in life, a value statement about what do you personally feel is most needed to advance the field. And I guess I personally feel that strong variability, whether you're talking about Weinberg-type variability across settings, looking at that, or variability across outcomes in subgroups, or variability across implementation. Like in this study I described to you, we've already predicted a priori that the sites that are more automated, that are more electronic health record, are going to do better than those that aren't. We've predicted that those sites that have behavioral health counselors to do and follow up on this are going to do better than those that don't. The overall trial may well have a null or a negative outcome, though, because of that. We took the risk, and it is a risk, admittedly, and if you propose this to a study section, you're taking a risk. So I admit that. So it's a great question. Maybe we can discuss it later. Let me take one more now, and then go on. Yes, sir.
It's actually two questions.
Okay.
One is a question. I remember going to see you at the Dissemination Implementation Conference doing data taker assessment.
Yeah.
And there was someone Bill Conrad from Cornell was talking about it. Once you have the paper published, it can take 15 years before you get a reasonably high rate of implementation. So I'm wondering if you could talk about this. So far in your presentation, it's all about conventions, but nothing about how do you get uptake on it. And the second question is the pace of technologic change. So remember Gary Bennett also talking about when there's a new iPhone that comes in every year, a new tablet, a new cell phone.
That's right.
So by the time that one is writing their application, whether it's grant or maybe it's crowdfunding, the software could be paid obsolescent in 5 years later or when the paper is published. It looks almost like the Apple IIe. So I'm wondering if you could comment about some of the challenges that we face.
I would love to. First of all, let me repeat those questions, and then I will pay you afterwards because that's just where I want to go. So thank you. So the first comment was at the prior D&I meetings, we have an annual big D&I meeting, and it was talked about one of the classic statements is there it takes on average, it's actually 17 years to translate for a research finding to translate into practice. What you actually didn't quite get, and the reference is Bayliss and Boren 2000, and I don't know if I have it here or not, but we almost all forget the last part of it, which is even more devastating. 17 years. Okay, for 14% of the evidence to translate. 86%, nothing ever happens with it. That's for the 14% that does translate. The other question was, what does that mean for something like e-health interventions, where the speed of technology is so out of line with the traditional funding thing, the 5-year funding cycle and that sort of thing? Let's take a look at that, okay? Here we go. So, I also want to put this in here because what I've told you so far is at least getting the attention. And as I said in my earlier, is necessarily shared widely across NIH, but NIH is definitely interested in pragmatic trials. To be totally transparent with you, like most things in life and implementation science too, different people mean different things by pragmatic trials and what they want. And again, just to be a little more clear even, some institutes will only fund pragmatic RCTs. Other institutes like ours are very interested in alternative design, some of the things that Hendrix does, some natural experiments we can learn from, some time series things, that sort of thing. Other institutes aren't, and that's just life, okay? It's evolving, changing time. It's interesting times we live in. So, bottom line, and I always say, most useful thing I usually say at talks like this is talk to your program officer. Okay, they will tell you kind of the inside and what those are in your institute. But now, the second disruptive innovation, besides breaking for comments in the middle, is this is solely unrehearsed. You're the first audience that heard it. This is Russ's, radical ramblings. Okay, this is not NIH. Okay, so anything else, take with a grain of salt that you hear here. So my argument to partially address this issue of the 17 years for 14% of the evidence, and particularly in technology-based things, is maybe we need a new bold standard. And I do have a few cohorts in crime here that are noted at the bottom there. I'm trying to think if any, you can read those names, your group here, but some of the leading people in the patient-centered medical home movement, and I should maybe particularly call out Kurt Stange, who's doing a sabbatical with us. So we argued that what we need is 5 R's, not just the 3 R's, but we need 5 R's to move things forward from the research and as an alternative to the traditional NIH pipeline that I'll show you in a minute. And those 5 are relevant and rapid, rigorous, but maybe redefined. I might mean something different than traditionally by that. Resources reported, to be honest, that one didn't work. That's cost. But we had to have an R, so that was as close we could come up with, was resources reported. And finally, recursive. And this also gets back to the question, I think, there. Let me just rip through these real quickly, and then we can have some discussion. So we'll come back to them. The 5 R's are what we argue is the new bold standard instead of the traditional gold standard, okay? Relevance. Well, what do we mean by this? In particular, we need studies that can address or be more generalizable to the bullet points there, say real-world settings, including low-cost sites, low-resource sites. A range of staff that can implement this. So not just the very best places in the world. That can have a range of end users, consumers, and participants, and a range, as I illustrated in that last study that we call MORE, of typical conditions of administration. So we didn't exclude all the places that couldn't do this on a personal health record and dump it immediately into an EHR, even though I know that would work a lot better, okay? And that's where we would want to go in 2020, but we can't do that today. That's just not the situation on the ground. I hope I convinced you, or at least got you intrigued to see if you can get some idea of this from the comment. I can't read here. Says the woman on your left too, says, but if it's not participatory action research, what is it? The person on the right says, dictatorial inaction research? Alienated sedentary research? Autocratic twiddle your thumbs research? I don't know. So, anyway, Here's my statement, the rapid that you pointed out, the pace of research. So, we argue, and this is in yet another paper that should be coming out. This was just accepted in Clinical and Translational Medicine, the kind of online journal that's somewhat associated with the CTSAs, is that we need changes all along on design, review, publication criteria, and more generally culture, in our research culture, if we're serious about this. We need a lot more adaptive, evolving designs. We also need a lot of fields. I know this group is involving a lot of engineers and things like that. I think that's really, really healthy, and to look at some of the rapid learning that it creates from that. So here is an illustration, and I apologize, this didn't quite work out, but what we're going to do here is, this looks like it's a year or two old, and I stole it from Bill Riley, but in the usual grant, if you had applied, it ended in 2012. We need to update it. You submit a grant, and if you were awarded the first time, which we know doesn't happen much, what would happen when your grant was awarded, you did your pilot, you did your recruitment and randomization, and it took a little longer than it usually does, which always, you did your intervention, your follow-up, and you analyzed and published. And then here is where the real lag comes in, looking for a replication or a review in the adoption period. These are the number of years, and this is a pretty standard if you're fairly successful, okay? And you didn't have major recruitment, if you wrote up, if your analyst was still available when your study was done and not off on 10 other projects, okay? So these are all the things, and these were, unfortunately my bottom line came in, these are all the things you would have missed in technology that didn't exist. This is, I'll take whoever, Bill's word for this, because I don't know, but these are all the things that didn't exist if you froze your design back here at the time of your application. So, what we might be able to do on that, if we just focus on this 2008 and 9 period, instead of the full, whatever, 8, 10, 17 years, we did something like this, and I don't have time to do it, but just focused over a couple of years. What about if we did a much more rapid literature review here, using, again, some of the Canadian procedures, and at the same time, instead of just doing the published literature, what if we did an environmental scan of the best practices that are out there in technology simultaneously? You can do that. Again, maybe not as conclusive as a Cochrane review, but certainly would cost maybe 1/10 as much and be 10 times as fast, okay? I'm not saying Cochrane reviews don't have an important place in the field, they do. But when you think about how many thousand applications you all are working on and the need to move that, think, what if we could do these two types of reviews and integrate them through what's called an evaluability assessment? That I'm going to skip, other than to say I think this is a really great concept that Laura Leviton from RWJ has brought up and used for the childhood obesity experiments, where you ask some questions just to say, does this intervention ever have a chance in hell of working in the real world? Early on, before and even as a funding criteria. Then you do, like industry does, type studies. Internet, you all can do internet A/B studies in a day, an hour on that. Do some N01 studies. Do some MOST studies, some adaptive design studies, things like that before you freeze the intervention. Okay, very, very quick, very small n, very rapid studies. Then look at some trials, like I'm talking about here, this application in diverse setting. The MORE project went from concept to we'll have final data in less than a year, as opposed to usually for a multi-site project like that would usually run like 8 years and cost at least 10 times as much. And then dissemination and implementation. We got some things. I know that's way too rapid, but just as a thought thing, and I'll be glad to come back to that later. But again, as compared to this, this model here that we have, which was what rightly pointed, doesn't work in your field. Okay? Okay, so let's move along. The other R, going back to R, is rigorous. And again, here, rigor, I think everybody would raise their hand like apple pie. We're all for rigor, but we all mean something different by that, or what aspects of rigor we value probably different. To me, what we're looking for is a balance between internal and external validity. And I will say, to be a bit provocative, as I look at usual criteria for quality of evidence, let's take the consort usual criteria for RCTs. 23 items, 22 on internal validity. Great items. 22. One, very general, vague, possibly word on generalizability. One item on external validity on 23. I think we need more of a balance to move forward if we're interested in translation. Again, I have nothing against basic research. I think we fully need to continue to do that. We've learned a lot from it. But if we continue to only do that, and that's the only thing that we reify, we aren't going to get much better. The, Berwickian thing, we keep doing the same thing over and over, we're going to get the same result that we have now. And I think what we can do is consider in advance what are the most likely potential confounding factors. And there's a number of incredibly creative people, some engineers, some mathematicians, some research design folks. We should all go back and read Campbell and Stanley or Cook and Campbell in terms of alternatives for how to design controls for things. Resource informative. This is one of my soapbox issues here. I think we need to report much more transparently on what does it cost to do an intervention. And we need two types of things. One, we need, at least the health economists that I've worked with and learned just enough to be dangerous from, we don't need a full-blown complete societal cost analysis where the Congressional Budget Office does this and runs it out, look at the downstream costs and how many deaths are we going to avert in 50 years. What we do need to know, and you need to do, and I would suggest report on, is if somebody wants to replicate or take your intervention, what's it going to cost them in their setting? Maybe first your study in your setting, that's the implementation cost, and then if they have a different setting, like different intervention staff, different way of recruiting participants, what would it cost them to do that? That's the information we need on. The reason we need this is I can tell you as I go around, and I've in various careers, worked in work sites, I've worked in hospitals, I've worked in primary care settings, I've worked some in schools and things. The number one question is not about your effect size, folks. It's about what does it cost to do this. And that question is not just the dollar cost, not just the equipment, but it's the resources, the supervision to do it here. And if you don't have an answer to that question, functionally, the meeting's over. You can go ahead and present your data, and they'll nod their heads and then say, we'll get back to you. Okay, but if you can't answer that question, the meeting is over. So, a plug for data. Recursive, what do I mean by this? I think we have a lot to learn, again, from engineering colleagues, certainly from the QI community here too, in terms of continuous improvement here. And again, this was we were trying to show in this evidence integration triangle. Again, in my experience, and I always challenge people, and maybe one of you can prove me wrong, but I've never seen anybody that's taken a publication, particularly that somebody else has done, and replicated it exactly and had it work exactly as it did in the published literature. And if you think about it, it shouldn't, because the context is always different. If nothing, time has changed, and time is a huge factor in terms of what the policy is, what the issues are, what the context, what those sort of things are over there, or recursively. Having said that, and I'm about ready to ring the bell to wake you up and then finish up here, keep in mind, as I believe it's George Box, although this is disputed attribution here, has said, all models and all methods, including the ones I've just been proselytizing on here today, are wrong. But some of them may be helpful. They're wrong because they're all oversimplifications of reality. All of them, okay? But they can be useful differentially for different purposes. And again, a H.L. Mencken quote. So to kind of summarize this section, relevant, rapid, rigorous, resources reported, or cost and recursive. And now, ring, ring, going to close out here, a couple more minutes on funding. Let's say you got interested in a little bit here, maybe just précis or a pragmatic study or whatever. You want to go, is anybody ever going to fund this? Well, there's at least one thing, and the one I know the best, a place, if you want to get into some of this crazy, wild and woolly world of implementation science, we've just rewritten a trans-NIH initiative. If you just Google NIH PAR for program announcement 13055, there is a variety of different mechanisms. I'll be glad to answer questions. I won't go into the minor differences among them, but they're in scale, whether it's pilot or a full-blown study. As we give, you can go up to $500,000 a year for up to 5 years. You can actually go over that if you come in ahead of time and get permission, I generally wouldn't advise that in that fiscal climate, but some people have successfully done that. We have 14, I think there's one or two aren't on here. Sorry for all the word salad, but I just wanted to get it on one slide. I'll be glad to answer questions if you have about institutes. We have more institutes than ever that have bought into this, including if any of you have international collaborations. This is one of the very few NIH mechanisms that where we're strongly encouraging international, and international investigators can actually be PIs, not just co-Is. Again, you may want to strategically have a U.S. investigator be a PI because they know the system and the game and they're known to review, but it's possible for international investigators. Equally, and maybe more importantly, we now have a standing study section that understands pragmatic trials, that understands dissemination and implementation research. We didn't have that until a few years ago, so you were pretty much at the mercy. Let's say you got excited about the things I or David Chambers or somebody talk about, then you go in and get massacred by people that are traditional clinical trialists. Okay, we now have a study section. It's chaired by Russ from Washington University. It has a number of names that you would know, and you can Google them yourself, that we're quite proud of what's happened there. More generally, there are other funding options that are out there. Like your investments, in this time we need to diversify our resource funding as well as our portfolio. PCORI, we can talk some more about that. I don't claim to speak for them, but those of you that are interested in patient-centered interventions, there's work there. I think there's a lot of you, to some extent even HRSA, certainly the VA that's interested in patient health records, electronic health records. Often I think a big area is mHealth applications that'll dump back into EHRs and that sort of thing, comparative effectiveness research. As I said, one thing, the collection and meaningful use of patient report measures. At least our institute's very interested in that, and I think many others, and we call that out explicitly in the newly revised application that I mentioned before, on the Trans-NIH application. Now I'm going to tell you about a couple other resources, and also one of the hurdles. If you do come in for this type of grant, one of the questions that the study section will ask, that's called the DIRH, Dissemination, Implementation, Research, and Health study section, is they'll ask, is your intervention evidence-based to begin with? Because this is not the place to go for a brand new idea. You do have to go somewhere else. Frankly, if I was you, I'd go to industry or a foundation for a new idea. But you need to have some type of at least efficacy or effectiveness data on it. If you have a brand new idea, it's not going to work here. But what you can do is you can either take somebody else's intervention that's been out there that you want to partner with. You can take a guideline or a Cochrane review or something that has established the evidence, that's based on evidence, and then use that as the basis to come in. And there are others. In our Cancer Control Planet, we have a section called Research-Tested Intervention Programs. We have over 130 interventions programs that meet the criteria. Given the time, I won't bore you with them, but I'll show you in the next couple slides here. And this is just celebrated our 10th anniversary, so we're kind of having a holiday. This is a rollout for our 10th anniversary, too, of these programs. We have 130 of them. Here's ones that have at least a large e-health or internet element. Now, there is a catch. Well, I ask because we partner with you to make these available to try and get around this 17-year thing. So what we do is we work with you to make available all the materials, all the training materials, all the measures, all the like FAQs, the guidelines, and things like that that you never see in the journal article, to make those publicly available to people. These can be proprietary, but we put that up in front, whether it's free of cost or proprietary. The one catch for e-health interventions, because we've gotten burned on this, is you have to be willing to continue to support it. Like if it's a web-based intervention, you have to be willing to continue to host the website for, we can negotiate, but say like at least a couple years. Otherwise, we put a pretty big investment, substantial investment into getting it ready and reviewing it, and what's the purpose if it's not, if it's like, unfortunately, my web-based interventions that Lee nicely talked about that are no longer available. You know, why should we promote those if they aren't out there anymore or being hosted? Okay, so let's see. So here, in the future, we're looking, and I would love to invite a lot more. Here's some of the things that we're looking at in the criteria. that we look at when we say this is what we mean by evidence-based interventions. I'll be glad to share these slides with you, and again, we would love to partner with these criteria. There's no charge, just a little time to work with us on that. What we do, the end result, it ends up on the web. You'll see a description of the summary of the program. We have summary scores, and what's highlighted here for this audience, because I was doing it, I have to confess my staff did this, I didn't, is we put some re-aim scores on here too. Or it'll just say not applicable if that's not been looked at. There's the website. We also have a little section, tried to get a little more interactive, of what we call notes, where you can make notes about how similar or dissimilar might this be to your situation as you're going along, to make it a little more interactive. If you find out you're kind of interested in this application, but it doesn't do so well, we have an automated tool called a self-rating quiz, which is also available on the re-aim website that Paul Estabrooks now runs at Virginia Tech, but where you can go through and kind of score yourself on dimensions. If you don't do so well, then if you choose to, you can click on and see what's worked well in programs that have high reach. Say if you didn't do well on reach, or you have some implementation challenges, you can look for some tips and guidance there. I am wrapping up now. So in general, evidence is a little bit like, take your pick, beauty or maybe pornography. It's in the eye of the beholder. Okay? It means different things. There are cultural differences in terms of what we mean by evidence, and evidence for what purpose. I personally feel we need a balance and a respect for different types of evidence that spans internal and external validity. I do think we need to think a little more broadly than we have in the past and consider evidence from multiple perspectives, and especially from those that we intend to use our application. Concluded. So thank you very much. And I defer to you two if we have time for some more questions or comments or what. Okay, we do have a few time. Let's see, I'll come back to you, but let me see if I can get somebody that hasn't spoken first. Although your last question was so good, and I don't see another hand, so go ahead.
I love your rendition of the 2008 to 2009, given the phase of implementing the trial opportunity to reconfigure the intervention. There's one huge barrier that I think is a showstopper, and that's IRB scrutiny over multiple changes of a protocol in a relatively short period of time. I wonder if you could talk about whether the discussion in the government is to help IRBs understand that we probably need some flexibility in adapting these trials to circumstances rather than the traditional pharmaceutical trial where protocols are secret or so that on the intersection treated without change over 5 years.
Sounds like you've lived in the same world I have. The question for those of you on this side of the room was the huge glitch or the Achilles heels is all this rapid innovation might be really nice and changing it. One huge barrier though, IRB and protocol revisions. NIH is aware of this. Particularly it became acutely aware of it in the CTSH when those came out. And it's two areas, I think, that get hit the most. One of them is you folks, is technology interventions. The other one, and things like social media in particular, things that really get hit, where you can't, and you're exactly right, because why were our IRBs developed in the first place? What is our whole model of research